Okay, the way this morning is going to work is I'm going to give a sort of overview talk that will start with clinical management. Now, as I've met many of you last night and this morning, some of you haven't even been treated yet for your eye lesion, eye tumor. Some of you have been treated, but haven't had any other problems since then. Some of you have been told you're high risk, and you're not sure what to do about that. Some of you have had metastatic disease. So we have the whole spectrum here. So I'm going to try to give an overview. I think most of you have had treatment of your eye lesion, so I'm not going to spend a lot of time on that. But I will just give an overview. Some of you may be wondering, why do I get an ultrasound every time I go in to see the doctor? Is that really necessary? And we'll talk about what it is that we're looking for when you come back in after treatment. And then we'll talk about prognostic testing a little bit. I would assume that most of you, if you've had treatment, would have had prognostic testing. If you were going to have it, it would have happened at that time. So again, a lot of this is water under the bridge, but we can talk about what is the latest thinking about prognostic testing and how do we use that information. And then really what my lab focuses a lot of our time on is understanding why these ocular melanomas metastasize, and how can we develop targeted therapies to address that. So we'll kind of go through that whole spectrum, and then I'm going to have Dr. Matt Studensky come up and talk a little bit about the way we do plaque radiotherapy. You know, that plaque radiotherapy is the most common type of treatment in the United States, and there haven't been big shifts in the way we do that, but there is a really, I think, very helpful and very important innovation that's relatively recent in the use of 3D simulation to identify the best isotope, the best configuration for plaque radiotherapy. So Matt's going to talk about that and probably some other issues related to plaque therapy, because I suspect that many of you have had plaque therapy, some have had proton therapy, and this will a lot of this will apply to that as well. And then Dr. Peter Hovland, where's Peter? Okay, Dr. Peter Hovland, good friend of mine from Denver, has a big ocular melanoma practice in Denver. He is going to join us, and we'll have a panel here, and we'll try to answer your questions, okay? And something I'll just preface now, and you know, for the panel discussion and for later in the day when I'm available to talk to you individually, you know, I can't give out medical advice to you on an individual basis, you know, unless I've seen you in the office as an official patient for medical legal reasons and just kind of common sense reasons. But here's Dr. Hovland. You missed your opportunity. I was going to hand out a big award up here. But just keep that in mind. We can't, Dr. Hovland and I and Dr. Sato and Dr. Patel and the medical, you know, all of us who are here to help you through, you know, this process, we can't give specific advice for you individually, but we can say, in this setting, generally, I would recommend this or that, but we can't hand out specific advice for you, just to keep that in mind. So without further ado, I'm going to go ahead and start, and feel free to interrupt me if you want to raise your hand, and I can answer questions as we go through. We can keep this fairly informal. This is my disclosure. Some of you may know I developed the technology that is now known as the Castle test, the gene expression profile. We discovered BAP1 in my laboratory, and we've developed a lot of technologies around BAP1 that I'll talk about as well. So this is just my legal disclosure. You know, we informally call this ocular melanoma, but ocular melanoma really is several different, almost completely different diseases. Conjunctival melanoma is, strictly speaking, ocular melanoma, but it's very different than uveal melanoma. The type of mutations, where it spreads, how it spreads, how it's form, we know it's much more associated with ultraviolet light exposure, for example, than is uveal melanoma. So we kind of lump these all together, but mostly what this talk is about is uveal melanoma. Now I can talk to you folks individually about conjunctival melanoma. We actually have a world's expert in conjunctival melanoma, Dr. Carol Karp, here at Bascom Palmer, that I work very closely with. She wasn't able to make it today, but certainly we can answer general questions for you about conjunctival melanoma. But uveal melanoma, probably none of you had heard of the uvea before you got involved with this condition. I thought the uvea was the thing in the back of your throat that dangles around, right? That's the uvula, okay, that's different. Uvea, it comes from the Greek word for purple, because when you look at it anatomically, it looks purple. And part of the reason it looks purple is that there are all these brown melanocytes mixed in with red blood vessels, and it gives it kind of a purple appearance. But also part of that is the iris, the part of the color part of the eye that you're all familiar with. Behind the iris is the ciliary body, and then connected to the ciliary body is the choroid. And melanoma can arise in any of these three structures and be called uveal melanoma. Now, generally, iris melanomas have a much better prognosis if they're isolated to the iris. They start in the iris, they stay in the iris. They have a much better prognosis. In fact, I polled all of the world's experts about 5 years ago and asked all around the world, can you produce one patient who had isolated iris melanoma that did not go into the ciliary body through the angle, that developed metastasis, and nobody could produce one case. Now, there's probably somebody somewhere in history, but it's striking, right? You know, it's really pretty rare. So we really kind of lump iris melanoma in our mind a little bit differently. And sometimes people will lump ciliary body and choroidal melanomas together as posterior uveal melanoma, posterior meaning behind. I tend to use the word uveal melanoma because it's sometimes hard to distinguish a choroidal from a ciliary body melanoma. Turns out that all a choroidal melanoma has to do is touch the ciliary body, and it changes the prognosis. It doesn't have to have arisen in the ciliary body, and we don't understand why that is. So when people distinguish ciliary body from choroidal melanoma, it's a little bit arbitrary, but be that as it may. Now, diagnosis, unlike a lot of cancers, like lung cancer or breast cancer, you can't really see the tumor. You're looking at an image, you're looking at a CAT scan, or you're looking at an X-ray or something. Here we can actually look directly at the tumor. And so with a lot of experience, we can be about 98, 99% accurate just looking at the tumor as to what it is. And that's why we don't do biopsies to diagnose these generally. Sometimes there's an unusual case, it has a weird coloring, or there's blood all over it so we can't really see it. But generally we can just look at it and be 95 to 98% sure. And so we look for things like the pigmentation, like you see here. If it has a mushroom shape, that is really pretty characteristic of a melanoma. And there's other features that can cause a retinal detachment and things like that. The ultrasound is really, really important for a number of reasons. First of all, it kind of cinches the diagnosis in a lot of cases. If we see what's called low reflectivity, you know, my arrow is not, I can't point with my arrow. I wonder if there's any way to make that happen. Oh, it is working. It's just not working. Huh. Okay, forget about that. If you look at those two arrows up there, thank you. If you look at these two arrows up here, that's what we call high reflectivity. So on one side is the tip of the tumor, on the other side is the base of the tumor. And all of these reflections on the inside are low. Almost nothing else does that except a melanoma because it's tightly packed and there are certain ultrasound reasons. But that's really, really helpful for us. So we'll often get an A scan it's called an A scan, to help us confirm the diagnosis. The Bscan is the more familiar, more understandable image, which is a two-dimensional image. And that will show us the dome shape, or here's the mushroom shape. We have a little bit of a retinal detachment here. And when you put that together with, you have some pigment when you look at it, it has low reflectivity, it has a mushroom shape, almost nothing else is going to look like that. So up until the time of prognostic testing, we rarely did biopsies because you didn't really need it to make the diagnosis. So that's a question that sometimes comes up with radiation oncologists, for example, who aren't familiar with ocular melanoma, and they're wondering why we didn't get a diagnostic biopsy. The other thing that ultrasound is really important for is that sometimes these melanomas can start to extend through the eye into the ocular, into the socket, eye socket, or the orbit. And that is something we have to be very aware of, because if we're going to put a plaque there, we don't want to dislodge that, or if it's really large, it might mean that we have to just enucleate the eye. So these are all reasons why we do ultrasound. Some of you may have gotten an angiogram where you get dye put into your vein and then they take a bunch of pictures. We don't generally do that on every patient, but we do that in selected patients when the other two things I just mentioned, you're still not quite 100% sure you have a melanoma. Here's a case where we think it's a melanoma, but it had a lot of blood around it, and we couldn't really see, blood, when the red color goes away, it turns kind of a brownish green, which can look very similar to a melanoma. So here, doing the angiogram, we could very clearly see that this isn't just blood, there's actually something with a blood supply there. So we will occasionally do an angiogram, but not on every patient. And then there are other things that some of you may have gotten. There's something called autofluorescence, which allows us, or helps us, to look for the orange pigment, which is one of the risk factors for melanoma in a small lesion. And OCT, that's where you look at this black space, and there are these little bars of white light. I bet a lot of you have had this done at some point. What that does is helps us to look at very, very high magnification at the retina overlying the tumor. It's not really good at looking at the tumor itself because all of the light waves get absorbed. Here's the melanoma down here. You really don't see, you can't tell much about it, but it tells you a lot about the tissues overlying the melanoma. And we get there's a lot of information in this one image. For example, here's an area of retinal detachment here, but this area, so that's a bad sign, but this area here is called a pigment epithelial detachment, and that's a good sign. So a pigment epithelial detachment. So that's a sign of something that's been there a long time. So in this particular tumor, this was a nevus that had been there for a long time with a lot of old chronic changes, but then it started to get active, and we can see the activity from the fluid under the retina that's detaching the retina. So there's no way we could see all of that just with the naked eye. So OCT is often helpful in especially in smaller tumors. So I just went through all those because some of you may be wondering, why am I in the doctor's office for 2 hours or 3 hours every time I go in and they do all this imaging and all that? Well, it all tells us something a little bit different, and it helps us to make better diagnoses and better treatment decisions. Is there any questions about any of that before I switch gears? Probably all of you are pretty familiar with that and pretty used to this testing at this point. Okay. So in terms of treatment, these are a list of most of the more common treatments for ocular melanoma or uveal melanoma that we see out there. And a major point I would like to try to make today is that any of these treatments, if done successfully, are about equally good. So if you hear somebody say, well, I had this treatment and it's much better than the treatment you had, don't listen to that. They're all equally good if done properly. Ocular melanoma is like a hornet's nest. You want to get the whole thing the first time. If you leave a few hornets behind, they're going to get really mad and they're going to come back for you, okay? So whatever treatment you do, you just want to make sure it's successful. You want a high local control rate, a low failure rate. So there are a few rare exceptions to that rule where one treatment is superior to another treatment based on the location of the tumor. But for the vast majority of people, plaque radiotherapy and proton beam are very, very similar. So, for most of you, this is going to be water under the bridge. And the point I would make is don't second guess the treatment that you had. Should I have had this? Dr. So-and-so says this is much better than that. It's really not. For the most part. Do you agree with that, Peter?
Absolutely.
It's just a lot of hype for the most part. You probably got the treatment that was best for you. Okay. Now, having said that, most people are going to get treated with some kind of radiotherapy. In the United States, that's usually iodine, plaque radiotherapy, or proton beam radiotherapy. And in some other countries, stereotactic radiotherapy is common. It's just a different way to deliver external beam radiotherapy. That they have slightly different pluses and minuses, but the main point is these are all variations on the same theme. Okay, and I think they're all good if done by somebody with a lot of experience with that particular technique. Enucleation is still something that we have to do, particularly in a very large tumor, a tumor that's caused a lot of bleeding or retinal detachment, or it's extending outside of the eye, and that's perfectly legitimate, and we do that probably in 10% of patients. All right, so these are all very legitimate choices in the right setting, and some of the jockeying about this is better than that, it's really more marketing, rather than true scientific differences. Would you agree with that, Peter?
I would. I'd say that there is a small failure rate in all of these techniques. It's usually very small, but it doesn't necessarily mean that the technique was not properly employed. There are some tumors that I think are perhaps resistant to the treatment, but they're very rare.
Well said. Well said. Now, one thing that here's your typical plaque surgery. We will mark where the tumor is on the outside of the eye. A lot of patients will ask, did you go inside of my eye to put the plaque on? The answer is no. We put this on the outside of the eye. And that's one of the advantages of this. We're not sticking something in the eye and trying to chew the tumor out or cut the tumor out. We don't violate the eye. When we first get started, we use the dummy plaque a lot to minimize radiation exposure. Those of us with a few gray hairs don't need those anymore. We usually get it right the first time when we put the active plaque on. And for me, it's very important, actually a technique I learned here when I was a fellow at Bscan Palmer, is ultrasound localization. In the era before ultrasound localization, the failure rate was 15 to 20% after plaque therapy. Now that most of us are doing plaque localization, our failure rate is 2 or 3%. So there was this, back in the 80s and 90s, there was this presumed advantage of proton beam over plaque because of the lower failure rate. But it turns out the high failure rate with plaques was just that people were not localizing them properly. Now most of us do that, and that failure rate has gone way, way down. This is just an example of my 16-year experience at Wash U in St. Louis before I came here. You can see that over that time, we had very, very few patients fail their plaque therapy. And those that fail tend to be very close to the optic nerve, where you're requiring a notch. And that might be a setting where proton would have an advantage over plaque, is when the tumor is right up against the optic nerve. And with the plaque, you can't quite get the plaque all the way around the tumor, whereas the proton beam, you don't need to worry about that. Now with proton beam, you tend to lose more vision, but you may in that setting have a little bit better, local control. So those are the kind of rare situations where you might prefer one over the other. But this is an example of before treatment and a couple of years after treatment of a relatively small melanoma. And another question I often get is, the patient comes back in 3 months, is the tumor still there? Well, for most patients, the tumor will always there will be a remnant of the tumor that's still there, but it's just a scar. It basically regresses to a pigmented scar. Now, there are rare cases where the tumor will completely disappear. But that's usually, I find that in less than 5% of patients. And it's usually where you get an immune reaction, where the tumor will become very inflamed after the treatment, and then it kind of disappears. We published on that a couple of years ago.
My doctor said mine is down to rubble or something, or?
It's what?
It said down to rubble or dust.
That's right. This is rubble or dust here. You know, right here. This is basically what they're talking about. You can usually always see some little remnant there. It's not like it completely vanishes. But the way that we know it's dead is that it slowly shrinks over a couple of years. And that's why we continue to get the ultrasounds and the photos so that we can make sure that it's slowly shrinking. Okay? A couple of treatment-related issues. There is a lot of talk now about doing injections in the eye to prevent or treat radiation complications. And there's there's really three main radiation complications that can cause vision loss or even loss of the eye. One is the macula. When the macula becomes damaged by the radiation, we call that radiation maculopathy. The second is where the optic nerve becomes damaged, radiation optic neuropathy. And the third is neovascular glaucoma, where that can cause blindness, pain, and even have to remove the eye. Now, I think most of us agree that there isn't really a treatment for radiation optic neuropathy. That's where you basically get a stroke in the optic nerve. There's not really a good treatment for that. However, for radiation maculopathy, there are a lot of us who think that this type of drug called anti-VEGF therapy, you may be familiar with the name Avastin or bevacizumab or Eylea. Do any of these names ring a bell to anybody? Yeah. So there's really, I would say, a spectrum of opinions. I have very esteemed colleagues who say, I never do any of this, it doesn't make a difference. And then I have other colleagues that say, I start injecting everybody every month for the rest of their life from the day their plaque comes off. All right? I'm in the middle somewhere. I don't inject people that don't have radiation maculopathy, but I will try it, especially if we catch it early. If somebody's had radiation maculopathy for 5 years, the horse is out of the barn. But if you catch it early, yes, we will try the injections, and a lot of patients will respond, and we will be able to keep their vision better than it would have been if we didn't do any treatment. But we also try to get patients off of these injections. After we've stabilized patients, we'll start to extend the interval between the next injection. Some people, it's like, oh, whoa, no, if you go more than 2 months, it all starts coming back, so you got to keep doing it every 2 months. Other people, we just keep extending it. Before you know it, they're off of it. So if somebody said, no, you have to have these every month for the rest of your life, I don't agree with that personally. And if somebody says these have no role, I don't agree with that either. I think the answer is probably somewhere in the middle. But I think the bottom line, if I can keep figuring out how to use this, is this right here. We really don't have any clinical trials. In most of medicine, when there's a question about one treatment versus another, you do a clinical trial and you compare and you find out which is better. This hasn't really been done. And Peter and I and folks in our field that want to work together, we're trying to do these kind of studies, but it takes money. So, that's where we need help in our field, is to get money to do these kind of trials. So we could answer this within a year or 2 years, right, Peter?
Yeah.
If we treated half the patients, didn't treat half the patients, we could have a pretty good answer within 2 years.
I don't think it'll happen. I think I like to think of this as one of those really things.
Push down the microphone, and I think that makes it better.
Calling Sam Adams. You hear me? I don't know if that's working or not. I have a pretty loud voice. I would say I agree with everything you're saying here. What this is really, when it comes down to the art of medicine, customized therapy, and it's going to be different for everybody pretty much. That's where we are now, because we don't have a science formula that will tell us what to do. And so I've just found some things work for some people. A lot of times people are not bothered by the radiation, but not just be leaking, bleeding, and we may watch that if they prefer. there's travel issues and things like that that play in. But actually interesting, though, we found that, strangely enough, some of these folks that are out 10 years will respond to steroid, but not other interactive. We have just 1 or 2 patients where they've gone from not reading the chart to actually reading out of the book, not responding to Avastin, but to steroid. I'm just raising that because I think you'll encounter your own situation, whoever you are, whatever you're in, and you'll be given certain options, and certain testing has to be done, and it's a nuanced conversation you have with your providers. So I think it's hard to generalize, but I'm with you.
I agree, and I think the words always and never are words that we try to avoid. When you hear an always or a never, I would put my skeptic's hat on, okay, because most of these are not black and white decisions. Yes.
In what area of the brain are the injections actually pointing to, and then what is Avastin, for example, supposed to do? Is there some sort of chemical reaction?
Yeah, that's a great question. Let me go back to here. I'm going to go right here. So the macula is back here, okay? And like Peter said, if your melanoma was up in the front of the eye and you got a plaque or even protons, it's very possible you won't even get radiation maculopathy. It's very, very related to how close the tumor is to the macula. So, but if the tumor is more back here, then it's more likely. Now, why are we focusing on that and not the retina over here? Well, it turns out that virtually all the vision that you're aware of is from this area right here. So if you get radiation retinopathy out here, you're not even going to notice it. You're only going to notice it if it's in your macula, okay? So what is this drug? So we inject the drug up here where it's far away from the retina and any structures that we might damage. So we put a little fine needle right in this area here called the pars plana, and we inject it into the vitreous cavity. And then the drug diffuses back and it gets into the macula back here. And actually what it's doing, it's a drug that binds and blocks a chemical called VEGF, V-E-G-F. And that is a normal chemical that's released when there's blood vessel damage in an attempt to repair the damage by bringing in more blood vessels. In your liver or your arm or your skin, that works great. But in this very critical structure, it doesn't work that well. Because what you end up with is a scar, right? If you have a scar on your skin where a cut healed up, that's great. But you don't want a scar forming right in your macula. So you're actually trying to inhibit the natural wound healing process in your macula. Does that make sense? Okay. And it's the same approach we use for macular degeneration and diabetic macular disease and things like that. It's the same type of principle. Okay. So the bottom line is there, again, that I think it definitely does help, and as Dr. Hovland mentioned, sometimes steroids can play a role. I try to avoid steroids when I can because you have the added problem of potentially getting a pressure spike in glaucoma, so I always start with Avastin, but sometimes when that's not working, we do try a steroid, But it's worth trying, but for me, the main determinant is if I still see a lot of healthy retina here, or not healthy, but a lot of retinal tissue here, all these cysts here, that's fluid. So if that drug can dry up that fluid, we may still be able to get some vision back. But at some point, if it's been there long enough, all this tissue starts falling out and there's really no tissue left. So at that point, it's really not usually successful. So, okay. Yes?
Dr. Harbour, can you talk a little bit about what you look for to determine when you can increase the time between Avastin injections?
Yes, so the question is, how do I determine how to extend the interval between injections? So what I typically will do is we'll have a discussion with the patient. We see a little bit of early, what you hope for is you've caught it early. You see maybe they've lost a couple of lines of vision, they're 20/40 or 20/50. They have a little bit of swelling. You say, let's do one injection and see if we get a response. So if we do an injection and we get absolutely no response, we'll have a discussion again. Do we do this again? Okay, a lot will say, you know, I didn't really love that. Let's just forget it, okay? Some will say, let's try one more time, right? So you try one more time. But the best situation is you do it one time and you see a beautiful response. You know, you see they improve a line or two, the swelling goes down 80%, and then you say, this is helping. So I would do it again at about 4 to 6 weeks, and then again at about 4 to 6 weeks, okay? And then after that, assuming that we're getting good responses each time, I would keep doing it like that until I've gotten all the fluid out that I can, and then I would start extending. So that's usually maybe 2, 3, 4 injections, and then I'll go to 7 weeks, and then I'll go to 8 weeks. And often we'll find early on that you can't go more than about 2 months or it starts coming back. But then after a while, maybe after a year, you find I can extend this to 3 months, you know, or 4 months. So it's kind of a play it by ear kind of approach.
Absolutely. Actually, I was just going to say that we find also that laser is sometimes helpful. The tricky part is to find what we call the benefit to the patient. That's what motivates all of us. We look at you guys and say, is this helping you or not? And it's difficult sometimes when, you know, Bill or I or our colleagues are looking at the eye, we see, I say, a storm on the horizon, and the patient doesn't notice it, we go, we better laser, you know, or something. So that's hardest when the patient doesn't notice it, we're recommending treatment. I think it's more common when the patient notices it. That usually will prompt an effort to try and treat it. And that's where the benefit is. It's hard to argue benefit if you're not really noticing it. Because you're the guys that are going through the experience, and we're just trying to help you.
Yeah, I can't emphasize that enough that, you know, if I have a patient who's 2,200, and I think we could get them to at least 2070, but they're like, you know, it's really not bothering me. Well, leave it alone. You know, leave it alone. Other people, they go from 2,200 to 2,100, and they see a big difference. To me, it's like, this isn't helping that much. They're like, oh, no, I could tell. Starting last week, my vision started getting bad again, and it helps every time you do this. So absolutely, we gotta listen to the patient. So one thing I think is much less controversial and more clear is that anti-VEGF therapy has greatly reduced the need for enucleation due to neovascular glaucoma. Okay, so neovascular glaucoma is caused by the same chemical, VEGF, VEGF, but it's when a ton of this VEGF gets released. It's usually when there's a larger tumor, more toward the front of the eye. And then the abnormal blood vessels aren't just growing in the macula, they're actually growing in the front of the eye. And they start closing off all the little structures that control the pressure in the eye. The pressure can go sky high, it can be very painful. And then in the old days, we would try to laser, but a lot of times this process prevents you from getting in a decent laser treatment. So then you're stuck. And a lot of patients, up to a quarter of patients in the old literature would get their eye removed later, not because the tumor was active, but because of the neovascular glaucoma. Now, I've done one enucleation for that in the last 4 years. Okay, you can see this is my own practice. As we started incorporating more Avastin and other similar drugs, my rate of enucleation has gone way down. So that's clearly been a success with the anti-VEGF therapy. Okay, I doubt many of you have been in that situation, but just to know that we do have that in our toolbox if you get into that situation. Yes?
Just one more quick question. So the measurement that you actually follow in regards to the effectiveness is strictly how better I see, or is there something that you have seen?
You're talking about the maculopathy?
About the Addison.
Yeah, for the maculopathy. It's really two things. So the most obvious reason to do the injections is if it's improving your vision and you notice it, right? That's the easiest. You know, we went from 20/50 to 20/20. The patient went from miserable to happy. That's a no-brainer. No, there's no argument about that. Okay. On the other end, the patient's 2,400. You've done 5 injections. They're still 2,400. They don't notice any difference. Most of us would stop at that point. There are a few who would keep going, but most of us would stop. The controversy is in the middle, where the patient's 20/50, let's say, we inject them, the edema goes away. They get a dramatic, beautiful response on the scan. Their vision doesn't improve. So some would argue, aha, it didn't improve, but if I'm not doing the injections, it would get worse. Okay? It's hard to prove that you prevented something, right? It's much easier to prove that you did something, you made something better. It's very hard to prove that you prevented something. That's where you have to do a clinical trial. All right? You take 100 patients and you treat them, 100 patients and you don't treat them. You say, look, we did prevent, because in those we didn't treat, a bunch of them got worse, and the ones we did treat, they didn't get worse, right? So that's the controversial area. And that's where we have long discussions with patients about, yes, we may be preventing you from getting worse, but we don't know that for sure, and we need to do a clinical trial. Is that okay? Any other questions about that before we move to prognosis, which I think I'm easing closer to what most of you guys are most interested in, I would think. Okay, great. So let's move to prognosis now. And I'm going to start with some information that probably most of you already know. This is long-term data, all comers with ocular melanoma, regardless of size, age, this and that. But if you look over a long term, 20, 30 years, you see a couple of things. First of all, not everybody develops metastatic disease. About half of patients will develop metastatic disease, okay? And, you know, somebody that, you know, every time you see a vertical bar, that means that's as far as that patient was followed, okay? So, you know, they may have started when they were 75 years old, and then at 90 years old, they passed away of something else, right? So, so only 50%, that's over a long period of 15, 20 years. So somebody tells you, you walk in the office, oh, you're going to be a 50% chance you're going to be dead in a year. That's just baloney, okay? That's baloney. That's looking at many, many, many patients, where that 50% comes from. Many patients over many, many years, okay? We're trying to get from what this is called population research to precision research, individual patients. And that's what a lot of my research has really been about, is to have data for you as an individual, not about a population, which only vaguely tells you anything about you as an individual. Does that make sense? Now, the other thing that's interesting here that people didn't really understand, maybe we're starting to understand a little bit better, is that, and people they've known this for at least 50 years, but there were a lot of theories about why it is and so forth. But there seem to be two groups of people getting metastatic disease. There's this group that very rapidly gets it within the first 5 years. And then there's this much slower group of people that can get it 10, 15, 20 years later, but much later in time, and by no means most of the patients, okay? It's a much smaller percent of patients. And I'm going to come back to what we think might be the explanation for that, at least in part, in a little bit. Now, why is it, we just talked about how good we are at treating the eye tumor. Why does anybody get metastatic disease? You know, if we're pretty good at killing the eye tumor. Well, we think that this ocular melanoma type of cancer has a propensity for very early getting into the bloodstream, going somewhere else in the body, and going to sleep and just sitting there. Like, who's the guy who fell asleep and woke up 20 years later and they were bowling? Right, okay. Go to sleep somewhere for 5 years and then wake up and then, whoa, what's going on here? And then start growing out, right? So, and we can't find those with a CAT scan or a PET scan or a PET CT scan or a MRI or circulating tumor cells. Circulating tumor cells are interesting. It turns out that most people that never develop metastatic disease, with ocular melanoma, breast cancer, other cancers, you will find circulating tumor cells. So circulating tumor cells alone don't tell you very much. It turns out that our cells in our body shed all kinds of junk into our bloodstream, all kinds of junk that gets filtered out and excreted. And just seeing a tumor cell in the bloodstream doesn't tell you very much. So it turns out that access to the bloodstream is not really what causes metastasis. So, you know, there was a concern for many years that just doing the surgery on the eye, you know, whether you're removing the eye or putting a plaque on the eye or doing a biopsy, you're spreading the tumor cells. You've probably heard about this. Oh, you know, biopsies, that's dangerous. You're spreading the tumor cells into the bloodstream. Well, it turns out that that's not really, there are tumor cells in the bloodstream already, and the body's pretty good at getting rid of them. They have to have undergone some kind of special change to allow them to escape your body's surveillance systems, and we'll talk more about that in a little bit. So going back to this issue here, there is a problem that we can't get away from unless we just started screening all 350 million people in the United States annually and lasering anything pigmented in their eye, which is nuts. You know, there's always going to be that patient who has some risk that they've had micrometastatic disease that we can't detect, okay? We can't get away from that. So how do we improve survival then? And I want us to think a bit about how this works. There's some point in time when a person develops an ocular melanoma and they don't have any metastatic disease, okay? That's pretty obvious. And then there's some point in time when metastasis happens and there's very few cells in the body, maybe just a few scatter cells, wherever they might be. We can't find them, okay? And that may stay dormant for a long period of time, but at some point it starts to increase and increase and increase. And it's only here that we can detect it with our best imaging techniques, PET scans, MRIs, whatever you want to try. So by the time we can detect it, there are millions of tumor cells in the body, okay? Now, add to that, if any of you are familiar, if anybody familiar with the Collaborative Ocular Melanoma Study, the COMS, I mean, it was a famous, big study, 20-year study, but it ended, about 10 years ago, and people don't even talk about it anymore. But it wasn't perfect by any means, but we learned a lot from it. And what the COMS used for surveillance was a chest x-ray and a blood test for liver enzymes, okay? So this is a cartoon, but this gives you an idea of how much metastatic disease has to be present for you to detect metastatic disease with a chest x-ray and liver blood work, okay? At this point, no treatment is gonna work. It's just not gonna work. So the first thing we'd like to do is, can we somehow screen people more intensively to bring this down so that we're detecting it at the earliest possible time using standard imaging techniques that we have? How can we do that without exposing every patient? We know only 50% at the most are at risk, and really only maybe 30% are at really high risk, which we'll talk about. You don't want to be doing intensive surveillance on everybody for a subset of patients. But if you could tell which patients are at high risk, then you could drive this down to here, where the patient, yes, they have metastatic disease, but you've caught it at a much earlier stage. And the other thing to think about here, when it starts to take off, it goes very rapidly. It might go very slowly for years, but once it starts to take off, it goes very rapidly. So this could be a matter of a month or two, right? So you want to be detecting this earlier. So perhaps therapies that aren't effective at all here might be a little bit more effective here. Okay? Seems reasonable.
Dr. Harbour,
Yes,
who are the high-risk patients?
we're going to get to that. Okay? So what if we can go further? What if we can say, okay, now we know who the high-risk patients are, we can follow them more intensively. What if we don't wait for them to have metastatic disease on an MRI or a CAT scan? What if we put them on adjuvant or preventative therapy or delaying therapy? So the idea is, we know they probably have micrometastatic disease even though we can't detect it, Is there a drug we could give them, or combination of drugs, or something that would keep Rip Van Winkle asleep a little bit longer? Okay? Okay, that would be great. And then the ultimate goal would be, can we actually identify which patients are likely to develop metastatic disease and actually intervene earlier in their eye tumor? That would be the ultimate goal, right? When they're still small, treat them, kill them before they even have a chance to metastasize. So let's think about how we could approach these. First of all, to answer the question that was just asked, how do we go from this very primitive COMS style surveillance to a more sophisticated surveillance for a targeted subset of patients, and maybe even put a subset of patients on an adjuvant therapy? Okay. Before I answer that, think about this. If we're going to put high-risk patients on, let's say, an HDAC inhibitor or Sutent or this or that, they all have some side effects, right? I mean, they're pretty well tolerated, but they can have side effects. If you had a 1% risk of developing metastatic disease, would you want to be on a drug that you might end up having liver failure from? No. If you had a 70% chance of developing metastatic disease, are you willing to risk a small, tiny risk of liver failure? Probably most people would. Yeah, I might be willing to risk a small risk of something serious if I know I got a really high risk of having a problem if I don't do anything. Okay, that's the concept behind prognostic testing. So the answer to how do we get a targeted therapy or targeted surveillance and then maybe adjuvant therapy, we do know, and we've known for many years, that there are certain features of the melanoma that make it higher or lower risk. If the tumor is larger, either its diameter or thickness, diameter seems to be better predictor. So larger tumor size, if it touches the ciliary body, if it extends outside of the eye, if it has epithelioid cells. You've probably heard of all these, and there are more. But the concept is that we can take all these and sort of lump people into low risk, sort of increasingly higher risk, and all the way to very high risk. And this is what's called a TNM classification, which is based not on any molecular information, but just on the anatomic information about the tumor. And this is really all we had up until maybe 15, 20 years ago. Now, there's still people who advocate that we should only use anatomic information to determine whether somebody's at high risk or not. But I would ask you, if you were this patient in this group, you're 3A, you have an 80% chance that you're not going to develop metastatic disease. Do you want to be on the trial or not? That might cause side effects. What if you're 2B? Well, you got a 10% chance. Okay, this group, you got a 30% chance. There's too many categories here. That's the problem. This is great for putting patients into different groups for population research. If you want to study 1,000 patients from Europe and 1,000 patients from the United States that all got a certain treatment, you want to be able to break them up like this. Say, yeah, we were comparing 3As from Europe to 3As from the United States. That's what this information is useful for. It's not good for taking an individual patient and saying, here's where you are on the graph, we're going to do this. It's just not that helpful. So, it's really molecular information that really drives individual precision medicine, okay? And in uveal melanoma, the first molecular markers were chromosomal markers, and I'm sure that some of you have had chromosomal testing. Chromosomal testing is much better than anatomic testing. So for example, monosomy 3 is where you've lost a copy of chromosome 3. But you have to have lost the whole copy of chromosome 3. If you lose part of chromosome 3, that doesn't count. It doesn't mean anything. You have to lose all of chromosome 3. So if you don't have a test that actually detects loss of all of chromosome 3, then that test isn't giving you all the information that you want. 6P gain is supposed to be good, but we now know, and we'll talk about later, it's better than being monosomy 3. They tend to be mutually exclusive. It's actually not great. It's better not to have 6P. 8Q gain is supposed to be bad. Well, again, it depends. If you gain all of AQ, that's bad. If you gain part of AQ, that's not so bad. So there's a lot of ambiguity here, and that's what led us many years ago to explore other options, and we have settled on gene expression profiling, which we think is superior to chromosomal testing. Now, my purpose today is not really to compare the two. I think they're both good. We think for a lot of reasons gene expression profiling is better, but the background of this is that gene expression profiling is you're looking at multiple genes and you're using pattern recognition software. Think about how you recognize your mother from your father. You don't look at every feature on their entire body. Within a split second, you see their nose, their eye, their eyebrow. You look at 2 or 3 features and you know it's your mom, or you know it's your dad, or you know it's your next door neighbor, okay? That's how pattern recognition works, is we take key features that are different between 2 different groups, and we use that in a powerful machine learning way to distinguish the 2 groups. Now, I won't go through all the research on how we discovered this, but basically there are 2 main groups, class 1 and class 2. Class 1 is about 2/3 of patients. Okay, these tend to be at lower risk of metastasis. Class 2 tend to be at higher risk. This is about 1/3 of patients. And the company that now does this is the Castle Biosciences company. They'll be having an opportunity to speak later. But basically, when this was still in my lab, what we endeavored to develop is a test that didn't require the surgeon to go in to your eye with a big needle and take out big chunks of tumor, because when you do that, that's dangerous. You can spread tumor when you do that. You can cause retinal detachments, bleeding, all kinds of problems. We wanted something you can go with a very tiny needle, one time, take a little sample, and that's all you need. So we developed a very sophisticated technology called microfluidics, using a microfluidics platform and this and that. But the bottom line for you is that this is easy for the surgeon. What's easy for the surgeon is safer for the patient. And so we've tried to make this very simple. There aren't multiple caveats about, well, was it this or was it that? It's very simple to interpret, and that's really been the goal of this technology. But beyond that, what gene expression profiling has helped us to do that you can't really learn from chromosomes or from how big the tumor is we're learning about the quote-unquote biology of uveal melanoma. It turns out that most of these risk factors that we knew about line up with the class 1, class 2. Class 1s tend to be smaller, they tend to be younger patients, they less often involve the ciliary body, they usually are not monosomy 3, and then the opposite for the class 2s. However, this is just much more precise than trying to add up all these other risk factors. But what's really important is that it was this gene expression profiling that led us to the discovery of BAP1. And we noticed that without going into a lot of the details, that if you have a class 1 melanoma, it's what we call differentiated. It more or less behaves like the cells that it came from, melanocytes. Whereas if it switches to class 2, it behaves like a stem cell, an embryonic cell. Embryonic cells, they move around. They don't obey the traffic laws. They go where they want to go, okay? That's what these cancers do when they lose this BAP1 gene. And it was really the gene expression profiling that helped us hone in on this discovery that we published in Science a few years ago. Now, the BAP1 mutation explains why monosomy 3 is important, because this chromosome is on chromosome 3. So you mutate or damage one copy of BAP1, and then from either your mom or your dad, and then from the copy you got from the other parent gets lost. Now you don't have any BAP1, and you can't prevent the cancer from metastasizing. So before, just knowing monosomy 3 was associated with metastasis, it didn't really tell you anything. But having the expression profiling and now the actual gene mutation, now we can drill down on that and develop drugs that can target that. Okay, so that's really been a focus of what we've been trying to do. Very quickly, I will mention, some of you may or may not be aware, that about 1 or 2% of patients with ocular melanoma will actually have a familial syndrome that can be passed on in the family, okay? A lot of times when you start mentioning genes, people will automatically think, oh, this passed on to my family. No, most of the time it's not. Genes are involved in everything in our bodies, and gene mutations cause virtually all cancers, and most of them are not hereditary. But a small percent, maybe 1 or 2% of patients will have a BAP1 mutation in their germline, so that they can pass this on to their children. And that won't mean that every child or everybody in the family will have ocular melanoma. Some won't. Some will have mesothelioma if they had exposure to asbestos, kidney cancer, and some other weird cancers. They can also get these weird nevi in the skin. So, you know, if you hear of a cluster, like there's this cluster of ocular melanoma in the South right now that people are looking into, it turns out that a lot of these people probably have hereditary cancer. You know, there's kind of a panic now about radon exposure and this and that, and they're spending millions of dollars on all this exposures. The first thing they should be doing is looking for families, because that's going to explain a lot of this. Yes.
Down south, aren't they all related to each other anyway?
That's what my parents tell me. That's what my parents tell me, but we'll leave it at that. You know, Florida's weird. It's like a mirror image. The further south you go, the further north you get. It's like by the time you get down here, you're back in New York. Okay, so I'm just going to pass on there. Now, the other thing that we keep doing with the gene expression profiling approach is that it's an ongoing approach where we try to keep learning new things. And all of my patients, or 99% of them, agree to be part of our ongoing studies. So, you know, we do a biopsy for their clinical care, and they agree to let us take a tiny sample to continue doing our research. And as we go on, we learn more and more. And one thing that we learn, if those earlier graphs that only went up to maybe 5 years or 60 months, we saw very, very few class 1 patients develop metastatic disease. There were a few. We thought it was about 5 to 10%. If you watch patients longer, you still don't see a lot, but you see more. You see a few more patients with class 1 tumors develop metastatic disease. And we've gone back, now we have 600-700 patients that are allowing us to continue monitoring them, to see how they're doing. And what we were able to do is go back and re-look at their samples, and what we found is that there was a protein that is expressed in patients who, these class 1 patients that develop metastatic disease, that wasn't expressed in the ones that didn't develop metastatic disease. And that protein is called PRAME, P-R-A-M-E. And that subset of class 1 patients, they're not class 2. They don't have monosomy 3. They don't have BAP1 mutations. They have mutations in another gene that we discovered called SF3B1 that I'll talk a little bit more about. And there's some suggestion that at least in some patients, their metastasis may be different. They seem to be less likely to go to the liver. They still often do, but less predominant. They may be more amenable to immunotherapy. So this is still an outstanding question, but it's new information that we can start to look into, and I'll explain a little bit more about that. So again, when we looked at our data set, all of the patients that developed, all the class 1 patients who developed metastasis had expression of PRAME, whereas the ones who expressed no PRAME, none of them have developed metastasis. So we've now validated this on multiple other independent data sets, and I'm sure that with more time and more patients, it's not going to be perfect. Nothing that we do is perfect, but we're fine-tuning our ability to prognosticate, okay? So what we can say now is that if a patient's class 1 and they have no PRAME expression, their 5-year risk of metastasis is probably around 1 or 2%, something like that. If they have PRAME expression in their class 1, then about a third of them are expected to develop metastases within 5 years. And then if you're class 2, that's about 70%. So we have a very low risk group, we have an intermediate risk group, and we have a higher risk group, okay? So what's kind of interesting to think about is this plot that I showed you earlier. Is it possible that we know that most of the early metastases are class 2 patients, but perhaps this flatter curve are mostly class 1 patients, okay? So what we are organizing right now is a second version of the Collaborative Ocular Oncology Group study that we originally did to validate the gene expression profile test that was called COOG or COOG. This will be COOG2. And one of the things we're going to look at is this very question: are these late metastases mostly coming from these class 1 patients? And we'll talk about why that might be important right here. Turns out that PRAME is a well-known protein in other cancers. In fact, it was found in metastatic cutaneous melanoma in a patient who was successfully fighting the melanoma metastasis with their immune system. So the researchers took the immune cells out of the patient and said, what are you looking at that you're successfully destroying these melanoma cells? And the answer was PRAME. So the immune system is capable, at least in some patients, of recognizing PRAME and destroying melanoma cells. Now, most of you probably are aware that immunotherapy has not been very successful in uveal melanoma. Most of these are going to be class 2 patients, but we would like to ask the question whether, if we have PRAME expression, maybe these patients would be amenable to immunotherapy. And as we'll talk about a little bit later, there's a whole explosion now in a new type of immunotherapy. Ipilimumab or Yervoy and Keytruda and the PD-1 inhibitors, these are all kind of non-specific immunotherapies. They basically take the brakes off the immune system and say, go at it, kill anything that looks funny, okay? And it doesn't work because the melanoma cells are really good at masquerading and hiding from the immune system. But there's a whole explosion, a revolution in immunotherapy called redirecting the immune system or teaching the immune system which cells to go after. And there are actually already trials in other cancers, including cutaneous melanoma, where they are taking the patient's T cells and teaching them to go after the cells expressing PRAME. You might ask, well, what about all the other cells in the body expressing PRAME? Aren't you going to get a lot of side effects? Well, it turns out it isn't expressed in normal cells. It's only expressed in cancer cells and in germline cells. Okay, so this could be huge. This could be a huge thing. We need to be working with companies that are developing these immunotherapies, these T-cell directed immunotherapies. And PRAME could be a big part of that. Now, some of you have been told you're 1A or 1B. How does that associate with PRAME? Now, the way we came up with 1A, 1B was, let me back up. The way we found PRAME is that we looked at every protein that's made in the human cell, and we picked PRAME out among all those proteins and said, this is the one that really distinguishes best between those who develop metastasis and those that don't. With the 1A, 1B, we were restricted to only the 12 genes that are on the gene expression profile test, the Castle test, as an initial before we could get all this other research done, which took 5 years. So the genes that we use to distinguish 1A, 1B are only based on those 12 genes rather than the 25,000 genes that we had at our disposal to find PRAME. So we expect that PRAME may be more accurate. However, there is a fair amount of overlap between the two. Turns out about 2/3 of the cases, there's agreement between 1A, 1B, and PRAME, right? So if you're 1A, most of the time you're PRAME negative. If you're 1B, most of the time you're PRAME positive. But there is 1/3 of the time when they don't agree, okay? So another thing that the COOG2 study will be doing is a head-to-head comparison between the two. Until that time, PRAME will be available because we know that it's of prognostic value. We've looked at multiple data sets now, so it will be available. But how best to use that data versus 1A, 1B is something we're going to be answering in the COOT-2 study. So, let's go to this group now. Let's say, okay, now we've got prognostic testing. We're pretty good at telling who's at high risk, who's at low risk. What are we going to do with these patients? Well, first of all, if we detect them at the time of metastatic disease, then we can use standard targeted therapy options that are already out there. And by targeted therapy, it can be anatomic targeting, so liver-directed therapy. You know, Dr. Takami Sato has really pioneered, although these technologies have been around, he's really been the one who has really looked at the spectrum from immunoembolization to radioembolization to chemoembolization and in a large number of uveal melanoma patients, and has really provided us with a framework for the proper use of these therapies. And it's generally agreed that these therapies are more effective if you catch the disease earlier. You know, it's going to be more effective to have chemoembolization if you have 3 or 4 nodules in the liver than if the liver's completely full of tumor. So we need to push that time clock back, like I showed here. You know, up here, chemoembolization is probably not going to work. Here, it might work. Okay, it might be successful in driving, you know, pushing this time forward. Now, some people would say, well, this is just a time lag. You're catching them a few months earlier, but they aren't really living any longer. I don't think that's completely true. I think we have patients, some of which we've shared with Dr. Sato, that are 4 or 5 years out. This isn't everybody, but it certainly helps some people. Okay, so this is kind of, we're taking baby steps. We're trying to move towards more effective therapy. All right, so what other targeted therapies? Molecular targeting. So we'll talk a little bit about the genes that we can molecularly target, and then we mentioned a little bit about immunotherapy. Here again is liver-directed therapy. This is a paper that we put out when I was at WashU that showed clearly that patients do better and live longer if we catch their liver disease early when it's nodular rather than later when it's more diffuse. So pushing that clock back, catching things earlier, we have better outcomes. Okay, so that's kind of the first baby step towards improved outcomes. And here are some of the liver-directed therapies that are available, and you'll hear more about these from the medical oncologist today, but I just want to give you an idea that there's a lot of work going on in this space, okay, that none of this was going on 15 years ago. All right, targeted molecular therapies. We now know a lot about the gene mutations that drive uveal melanoma. We think that GNAQ and GNA11 are the initiating events, and so there's a lot of work being done to target those mutations, and we think that's very appropriate. Things like MEK inhibitors, PI3 kinase inhibitors, you've probably heard of some of these things. However, we doubt that this is going to be sufficient because that's just the initiating event. That what really causes these tumors to metastasize most of the time is BAP1. So we feel like you're going to have to target BAP1. The tumors that go down the different route to class 1, some of them develop something called an EIF1AX mutation. And this seems to be protective. Patients with this mutation rarely develop metastatic disease. So that's really good if we find an EIF1AX mutation in the primary tumor. If they have an SF3B1 mutation, as I mentioned earlier, these tend to be the ones that express PRAME, and they're at somewhat higher risk of mutation. So how do we use this for targeted therapy? Well, as I mentioned, we can target the GNAQ, GNA11, not directly but indirectly, with things like PI3 kinase inhibitors, MEK inhibitors, PKC inhibitors. These are basically proliferation inhibitors. BAP1 is basically what we call an epigenetic modulator, like Dr. Stefan Kurtenbach mentioned last night. This is another exploding area of research in cancer biology, or epigenetic modulators, okay? And we're very excited about this area because these are well-tolerated, very targeted therapies, And if you might recall, Dr. Kurtenbach showed you where if he treated with one epigenetic inhibitor, he got a little effect. If he treated with another one, he got a little effect. If he treated with two of them, he got this amazing effect. So this is what we're trying to do, is to think of combinations of epigenetic therapies in patients with BAP1 mutation. Now, the other thing that we're working on alongside of this is, I've talked to several of you last night that were saying, boy, it was really when I was found to have a BAP1 mutation that the doctor was able to prescribe a specific drug for me. Well, the problem is that using standard tests that are available, like Foundation Medicine and things like this, they only pick up about 80% of the BAP1 mutations because they're very complex, large mutations. So my lab has been very active in developing better ways of finding the mutations. We can now find over 95% of the mutations. The last thing you would want is to have a BAP1 mutation and the lab not be able to find it, so you didn't get a drug that might have helped you because the lab just didn't have a sophisticated enough test to find the mutation. So we're up to 95% now in my lab at finding these mutations, and we're working with Castle Biosciences to eventually make this clinically available. And then, as I mentioned, PRAME might be a target for immunotherapy, and this is a very exciting space for the future. And this is just to give you an idea. Again, you're going to hear more about this from the other speakers, but look at all of the trials. We have adjuvant trials that were never available before. We have targeted therapy trials that are for GNAQ, GNA11 mutations. We have immunotherapy trials. When I got into this field, there were no trials. They would laugh at you if you even talked about having a uveal melanoma trial. So it's really folks like you pushing the issue and getting involved that's forced the field to have these clinical trials. And that's the only way we're going to go forward. We probably won't find the home run magic bullet the first time we go to the plate. But if we don't go to the plate and take a swing, we're definitely not going to get a home run. Okay? So here's even other trials that are coming open. You're going to hear more about this from other folks, but there are completely new types of therapy that we can't even really call chemotherapy. They're just amazing feats of technology. One type is called an antibody drug conjugate. You're going to hear more about this later today. This is being used in uveal melanoma patients to tell the immune system to go right there to that cell, kill that cell. Okay? What I mentioned before, T-cell redirection therapy. This is also being used in uveal melanoma in clinical trials right now. It's a similar technique to teach the immune system to kill these specific cells. You're going to hear from the company Iconic. Wendy from Iconic is going to be speaking later today. They've developed this amazing high-tech molecule that will target the immune system and probably the angiogenesis as well. So the exciting thing is that uveal melanoma, even though it's such a rare cancer, we're now getting attention from the best scientists in the world and the best pharmaceutical companies in the world. Okay? So this is amazing, and you should all be proud that your efforts are forcing this issue and forcing people to pay attention. So for sake of time, I'm going to go very quickly over this last part. We've shown that if you have a smaller, even if you're class 2, if your diameter is less than about 12 millimeters, your risk of metastasis goes from 70% in 5 years down to something like 10%. So that might be telling us that if you're class 2, you became class 2 very early. Okay, it didn't happen late, it may have happened very early. And yet, there may be some time period before you actually successfully develop, before the tumor successfully metastasizes, even if you're class 2. So there may be an opportunity to intervene in the primary tumors earlier and kill it before it has a chance to metastasize. But how are we going to do that? The problem is that we've been talking only about uveal melanoma, but for every uveal melanoma patient, there's going to be 8,000 other people out there with a pigmented tumor in their eye that looks like a melanoma. We call those nevi, okay? And it can be very hard. Now, most of the nevi are easy to distinguish, but maybe 100,000 a year in the United States are not so easy to distinguish from a uveal melanoma. And yet, we don't want to plaque or nucleate 100,000 people for maybe 5,000 that actually have a class 2 tumor that needs prompt treatment. We also don't want to biopsy 100,000 people with little tiny tumors with great vision, risk damaging their vision. So the next, there are risk factors that we use. The risk factors that you may have heard of, thickness, orange pigment, et cetera, they were actually all discovered by Don Gass right here at Bascom Palmer. But what we've shown is that these risk factors, even though they predict growth, they don't predict class 2. They don't really help you determine which small tumors you should treat, which small tumors you can watch. So looked at another way, when you start looking at these small tumors and you start trying to treat them, there's a ton of people with nevi that don't need treatment, and we don't want to be unnecessarily treating them to treat a few people who need treatment. And we don't want to be biopsying all these people either. So we're also going to be in the COO2, we'll be looking at new liquid biopsy markers. The goal would be to not even have to biopsy the tumor, but to be able to take blood sample that we can take at multiple points over time and see if a BAP1 mutation has developed based on something that changes in the blood. So that's going to be the next big horizon. And I'll just close by mentioning a little bit more about the COO2. It's going to be at 27 centers throughout the United States and Canada. Dr. Hovland has a big center in Denver. Here are the centers that will be participating. It's going to be a large multi-center, multi-year prospective study that should be up and running before the end of the year. So I can give you all more information on that. And we're going to be looking, as I said, at PRAME versus 1A, 1B. We're going to be looking at next generation sequencing for these mutations and then looking at new liquid biomarkers. And finally, I just want to encourage you all to participate and to encourage your counterparts to participate in clinical trials. Even if that's just allowing, like the studies that we do, allowing a little bit of a biopsy that was going to be done anyway, allowing a little bit of that to be used for research. Everything you've seen today is basically on the shoulders of those patients who allowed us to not experiment on them or do anything different than we would have normally done, but to take a little bit of that sample in a de-identified way and to learn the things that we're learning. And these clinical trials, we might go up to the plate the first time as a rookie and hit a home run, but probably not. We might be lucky just to get to first base, right? But if we don't go to the plate, we're not going to get a home run for sure. So we have to do these clinical trials, even though they may not work. They may not work the way we want it to. We can learn from each one. We might learn what patients aren't going to respond, or that small group that did respond. We might be able to say, this biomarker tells us now these 5 or 10% that'll respond. So please participate in clinical trials when new patients with ocular melanoma gain access to your community of patients and advocates. Encourage them to participate, because that's how we're going to learn. And I just want to thank you for your time. I know I went over quite a bit, I guess, yes. And this is my lab and our clinical group. I want to thank all of them. And I want to thank, is Marla here? Is Marla here? She's around. She's around. I want to thank Marla very much for everything she's done to help us. My nurse, Barbara, my clinic coordinator, Catherine, who have helped tremendously. And now I want to turn it over to Dr. Studetsky, who will just give us a description of how he designs the radiation plaques, and then we'll have time for some questions.
Thank you, Bill.